begin. This session is sponsored by Exact Sciences as part of their generous platinum level sponsorship. And I'm pleased to introduce Dr. Jorge Rodriguez as our speaker. Dr. Rodriguez's research and passion lie in the meaningful intersection of medicine, social justice, and technology. He is a technology equity researcher and hospitalist in the Division of General Internal Medicine and Primary Care at Brigham and Women's Hospital and Harvard Medical School. He completed his internal medicine training at Massachusetts General Hospital. He also completed a clinical informatics fellowship at Beth Israel Deaconess Medical Center. Prior to his current position, he was medical director of clinical informatics at Lawrence General Hospital, where he oversaw an electronic health record transition in a safety net hospital. His work is focused on bridging disparities in patient-facing health technology, including patient portals, mobile apps, and telehealth. Dr. Rodriguez once jumped into a dormant volcano in Colombia. Welcome, Dr. Rodriguez.
Can you guys hear me okay with this microphone? Is this working? No. What about now? Is that any better? Oh, nice. All right. I'm the type of person that, when I'm on the phone, I walk around all over the house, and so this applies to presentations as well. So thank you so much, everyone, for having me here. Really excited to speak with you all. I'm humbled to be here, inspired by all of you here. I've been learning and chatting with many of you and all the great work that you all are doing. And today I'm hoping to share a little bit about our experience with striving for digital health inclusion. To start, I'll say I have no disclosures to report. I'm hoping to cover a few things here today. First, just level setting a little bit and defining what digital health, or the way I think about digital health inclusion. Second, we're going to talk a little bit about why now. Why are we here all now talking about this? Why am I up here talking about this now? And then three, I'm hoping to primarily focus on how do we actually achieve digital health inclusion, which I think brings together a lot of the thoughts that we've even brought up at the plenary this morning. So when I think about digital health inclusion, I sort of borrow from a health equity definition, which says that everyone should have a fair and just opportunity to engage with and benefit from digital tools. Now, digital tools is very broad terms. It could be all sorts of things. When I'm speaking about digital health tools, I'm specifically talking about mobile health apps, patient portals, remote monitoring tools like remote blood pressure monitoring or sending your sugar levels if you have diabetes over to your clinical team, and increasingly telehealth. But again, why are we talking now? And I think it really has to do with three things that came together to really make this the focus. First, it was a wild weekend that happened back at the beginning of the pandemic. You see there in the light blue, primarily in-person visits, and then they end, and you sort of see this shift to green, the primary telehealth visits. That was literally a Friday to a Monday. And if you think about the healthcare system, having anything change over a weekend is nearly impossible. And we had to do that for telehealth. It was a huge shift in how we were delivering care. The second thing that happened as the pandemic progressed is vaccines were developed. Wonderful. But we had to then get those vaccines to patients. And a lot of those initially relied on being able to go online and sign up either on your portal or on a public health site to sign up for this. That sounds a bit challenging for some patients. I'm sure people are thinking about this already. And then the third part of this, and perhaps got less focus, was the enactment of the 21st Century Cures Act. Some folks have talked about this already in some workshops throughout the day. But the 21st Century Cures Act essentially gave patients more access to their data. It put into law that health information belonged to the patient. And you could do many things with your own data, including being able to review it to improve your health outcomes. So it basically said, for example, things we do often in the financial system. We take our banking data and we port it over to apps, for example, Mint, and we're allowed to do that. So it basically said patients should be able to do that too with their healthcare data. And so as we start thinking about this, there's this language that comes up. We're now a digital-first healthcare system, right? That's sort of a language that we often hear. But as we sort of made this shift, at the same time, we also saw this. This is data from our organization which looked at, this is an example of video visits. We looked at video visits use early on in the pandemic to compare who was using video visits and who was using telephone visits, with the argument being that there was some benefit to using video visits over telephone visits that might benefit patients a bit more. The story that we've all heard at this point, but basically found that people from marginalized communities were not accessing video visits as much. Black patients, Latinx patients, older patients, patients who were Spanish speaking in this case, those who had access to broadband, they were all less likely to use video visits. And so when I think about a problem, I always like to take a step back. I was like, this can't be the first time we're facing this. Is there anything in history that can help us think through this? Could we have foreseen this in any way? So you go back, if you guys will time travel a bit with me. Now we're time traveling here in Madison, Wisconsin. Going back to 1925. This is like one of those futuristic magazines from 1925 that described this new system, the way we would be able to deliver care. Now I'm going to use this fancy pointer tool here. Up here, in the top corner, you see a clinical team on one side and a patient remotely on another through a screen being cared for. And the clinician there, you can see using a device which they called teledactyly, which we still don't have now actually, which allows them to basically examine the patient remotely. Now if you take a look at the center piece here, the bigger image here, you dive a little bit deeper and you say, all right, what do we need to get the system to work? And so you need a robust radio wave infrastructure. You need radio wave services that are affordable to patients. You need devices on both ends that are affordable and have clear upkeep. You need both parties to be able to use and have the literacy to be able to use these tools. So even in our wildest imagining in 1925 of how the system might work, we see a lot of the same challenges that we're facing today in 2022. And so I really think this sort of provides us an opportunity to reimagine the way we deliver care and reimagine the way we deliver digital health. And so I'm hoping to spend the rest of the time talking about how we might go about that. How do we actually achieve digital health inclusion? And in order to kind of jump in and say, all right, we're going to do this, we're going to deliver digital health inclusion, we really have to go in with the idea that there's an opportunity here. There's an opportunity that's being missed. And the opportunity that I believe being missed is that we can use digital health to address some of the disparities. But in order to be able to do that, we have to start from the beginning with the idea that we're going to do that. And that's where we haven't done a great job. Back in 2009, when the HITECH Act came out and a lot of funding came through for electronic health records and patient portals to be deployed throughout the healthcare system, we saw that there were a lot of gaps that were developed. There's data from 2010, 2011 that basically shows a lot of the same things I showed a couple of slides ago. So we knew those issues were there. And two, a lot of these were not tailored to the needs of diverse populations, as you all have mentioned today. So that's sort of the first opportunity. But the second opportunity, and perhaps the most important, is it allows us to develop a new relationship and maintain those relationships with our patients across distance. And I think that's the most important, because a lot of us went into this not because we like computers or odd things. It really comes down to the patient in front of us, the patients that we're taking care of, those relationships that we built up. I know when I'm having a tough day, I work as a hospitalist, when I'm having a tough day, sometimes one of the things that really gets me going is going out and talking to my patients. And that's really what we're trying to build on here. But so far, in the way we've delivered digital health, it's been fragmented, as you can see visually or with my dashed line that I was trying to exemplify there. But what does it take to take that fragmented line of digital health and make it whole and really make that connection and that relationship that we want with patients? That's what we're going to talk about. It's going to be a little bit of a whirlwind ride through each of these 5 domains of how I think about digital health inclusion. It includes 5 categories: technology access, technology literacy, implementation considerations, policy, and how do we think about delivering digital health as standard of care. So tech access, perhaps the first thing we often think about, right, when you think about like how do we deploy a digital tool, people are digital divide, gotta think about digital divide. And we know that at least 21 million people in the US lack broadband internet access. And I always highlight the little parentheses there of at least, because we know that some of this data probably underestimates how many people lack internet access. And if you think about, all right, then who are these people? It's often the same populations that we see have often the worst health outcomes. So there's sort of this overlap of you don't have, we think this technology is so great, so we should apply it to the patients that are really struggling with their health, but at the same time, those patients don't have access to that technology. A little bit of a conflict there. So how do we go about addressing some of these technology access gaps? One is around broadband infrastructure, actually laying down a broadband wire. 2 is addressing affordability. And then 3 is thinking about how do we, as healthcare system, be able to screen and identify our patients' digital needs and then refer them to the appropriate programs. Some of these issues, like the broadband infrastructure, are really tough, I think, as a healthcare system to take on. I can't imagine a healthcare system going out and saying, like, we're going to actually go out and lay down broadband wire, right? That's probably pretty kind of tough. There's a lot of other things going on than being able to do that. And that's where I think a lot of federal investment comes in. There's been, I think earlier there was mentioned a new law that came into place. There's a little bit of a teaser that I'll get to later and see how that might influence this. The other component to this is more of a structural component. We often talk about structural drivers of a lot of the disparities that we see. And that's around digital redlining or discrimination in the way internet service is being deployed or implemented. So an example of this might be an internet service provider might provide very high cost in a certain area. That's the only plan that's available. Or they might provide very low speed in a certain area. That's the only plan that's available. Or both, very high cost, low speed. The worst combo there. And those are often in the same communities that, again, when you look at a map or you often hear about, your zip code determines your outcomes, those are often those same areas that have our marginalized populations. And again, tough for a healthcare system itself to address this, but with a new policy that's come into being, against another teaser number 2, I think we have an opportunity to be able to address some of this. The other component here is around affordability, right? You can have the broadband go to your house, but being able to have the device and the internet to be able to use it is key. And for a long time, I think I lost it. That's been a struggle. And can you guys hear me still okay? Okay. And I've seen some healthcare organizations have really tried. They're trying to do the best by their patients, so they say we're going to buy like a bunch of iPads or Amazon Fires or whatever it is, a bunch of devices, and we're going to give them out to patients. Great. I'd argue, though, that it's a little bit more, it creates a little bit of a sustainability challenge. Are we saying that every patient that comes into our door, we're going to screen them for digital health, and then every healthcare system is now going to give them a device as part of their care? Maybe. That might be a way to do it, but it creates a sort of sustainability challenge. And I think some of these new programs, like the Affordable Connectivity Program, really provide a potential solution for this. It provides a $30 a month subsidy for internet, $100 towards a device. And I like to make a point of stopping here and really bringing this to the attention. Perhaps this group is well versed in this program, but there's a lot of crowds that don't know about this, especially in the healthcare system. They're like, oh, what is this program? And there's been evidence so far that the uptake of things like the Affordable Connectivity Program have not been as robust as it's been there. But this is kind of federal money coming in that we can use to address some of the gaps that a lot of our patients face, and doesn't necessarily mean that our organizations have to take on this whole new responsibility. So I always go definitely check it out if you haven't quite yet. And thinking about that, in order to be able to do that, you need to be able to screen and refer to patients to these programs. So one of the other big questions has been, how do we identify patients' digital needs? When do we do it? How do we do it? And that's, I will present a few different options. I think they're still sort of evolving as like what the best practice is. Some of them have been direct asking of patients to say like, what are your digital needs? What are the devices? What are the internet? What are your digital literacy? But there's a lot in there. How do you actually ask those questions? How do you do it in a way that's pretty quick, that you can do effectively, that you can then integrate into your electronic healthcare data and be able to review? One program that we've worked with has been working at the point of discharge. So when someone's leaving the hospital, they often have follow-up visits that are set up, and some of them are virtual visits. And how do we make sure? So we've been screening patients to make sure they have access to these, to all the technology they need to make their visit, because it doesn't make much sense for me to say, well, you have follow-up in a video visit in 2 weeks, and the person can't attend that visit. Not a very useful visit. The other one, which I also like to highlight, is from my colleagues at Johns Hopkins, where they actually use more of a data-driven approach. They use electronic healthcare data to try to identify patients who either hadn't used the portal recently, hadn't done e-check-ins, hadn't done a virtual visit recently, and they basically kind of flag those patients to say, are these potential patients that might need extra help going forward as we deploy digital tools? I found this to be a little bit less work intensive than kind of going out and kind of engaging patients directly, just purely in terms of a workflow piece. It's probably easier to ask a data analyst to go out and like do the data-driven approach, at least as a first pass. And then once you've understood that, then you can then go out and say like, well, now we have this great affordable connectivity program. I've identified you as potentially being eligible. Now let's go connect you with that. So I think there's ample opportunity to address some of the technology access pieces here. So we've talked about technology access, and now I have the internet, I have a device, I'm ready to rock and roll, and then this whole, the whole crowd here is kind of like, no, what about literacy, right? That's what you all are thinking. There's a big component here, technology literacy. And so for technology literacy, it brings a couple of things up. One, it's the actual platforms, and that was mentioned earlier, someone mentioned it in the crowd earlier today. The role of digital health navigators has kind of taken a bigger focus, and I'll tell you a little bit about that. And then collaborating with community organizations around this. So to start, this brings up, I think perhaps my favorite part, of my personal favorite part of the talk, is the part where I get to, one, have you think about your favorite apps, and then two, I get to tell you of one of my favorite studies that I talk about. So I'm pretty pumped. So if you can just take a few seconds as we're chatting here and think about your favorite app. And while you're doing that, I'll tell you about mine. My favorite apps are my podcasting app. Big fan of the podcast. The second app, I'll admit, I use social media. So Twitter and Instagram are also big on my app use. So I hope you've been thinking about your favorite apps. And then keep that app in mind as I tell you about one of my favorite studies. And this is a study that came out of the University of San Francisco in California. Dr. Umi Marlasar to their safety net clinic, and they had a series of apps that were for chronic diseases, diabetes apps, hypertension apps, and they basically said, let's see how good these apps are when dealing with patients who are sort of from marginalized communities. And they asked the patients to perform data entry tasks, like put in your sugar level, and data retrieval tasks, like review your sugar level. And they said, let's see how many of them they can complete. And when they saw, patients were only able to complete about 50% of the tasks. Now, if you just think about that app you were just thinking about, or perhaps using, if you weren't paying attention to me, if you think about that, if you think about Instagram, if you were only able to post pictures but not able to see them, it probably wouldn't be a very useful app. And that's the kind of environment on the app space that a lot of our patients are facing in being able to use a lot of these tools. And again, creates this weird combination of there are patients that really need a new tool, but they're not able to use this. And this is related to the actual platform, rather than a patient's literacy. There are some combinations of literacy, but it also comes to the platform. We did a similar study where we said, well, let's look at diabetes. Diabetes, often in Spanish-speaking populations, higher incidence and prevalence, often worse outcomes, worse complications, end-stage renal disease comes with it, amputations, all sorts of things that happen. If digital tools are so great, then all these diabetes apps should just be like, most of them be in Spanish, right? They're just like, make sense. And we looked at 92 apps in the iOS and the Android store, and only about 20 of them, or 22%, were actually available in Spanish. And the readability level was pretty high as well, even in Spanish. We didn't check understandability in some of the other pieces of health literacy, but we at least did readability. And I will say, kind of anecdotally, some of the translations left a lot to be desired. It was clear that someone had not like, there was one for the back button, right? When you think about back, you're like, oh yeah, go back. But the other thing that back can mean is like your physical back. And so for this one app, they had translated into your physical back. So it basically said like, go forward, or like espalda, which is like your physical back. And so not very useful, even if they had translated it. So it kind of presents what our patients are seeing out there. And so when we talk about equitable platforms, I always like to take a look at what's in the area that I'm presenting in. This is what I could find from the Medical College of Wisconsin and UW Health MyChart. And so if we look at this, there's something for me that's missing. And some of the things that are missing is if I was a non-English speaker, I probably couldn't figure out how to use this. If I was a non-English speaker over here, probably couldn't figure out, at least in my own language, might be able to figure it out, but it wouldn't be easily accessible up front. So if we say we're like a digital first healthcare system, this is our digital front door, what are we really saying here to patients? And how does that then connect with things like the culturally and linguistically accessible guidelines that exist for so many other spaces of healthcare, right? We're sort of saying that, well, in the analog space, we've all gotten those notices from healthcare centers that have like things in like multiple language on the front and back. I'm not sure if you've seen those, but we don't have a similar thing for the digital space. And so I present here, this is from another organization that's done some work around translating their patient portal into multiple languages: Spanish, Portuguese, Russian, Haitian Creole, and Mandarin. I will say it's taken a lot of work and a lot of effort in terms of like upkeep, and I can talk a little bit offline about that. But it is possible to include these and say to present, we able to treat you, and we want to be able to treat you in a language appropriately, even in the digital space. And then this brings me to my other point around sort of the stakeholder here that I haven't like directly highlighted has been the vendors, the people who are developing these tools. In a healthcare system, we have power when you have that first interaction with a vendor and say, hey, we're looking for a platform to manage our patients with high one of the things we can do up front is ask those questions around how did you develop this? What usability testing did you do amongst diverse populations? Did you include a linguistically diverse population? And having those questions up front can really make a difference to say, if someone comes to us and says, well, we didn't do any of that, they were all well-educated, English-speaking folk, that's all we did, then you might take a step back like, well, this might not be the right platform. Because once you've bought that platform, then you're sort of stuck with what we've been doing so far, which has been retrofitting, hacking our way away, trying to figure out how to make it work. But there's opportunities here to be able to ask questions up front that drive at digital inclusion. But even if you have the best of the best platform going on, there's some patients, as we know, that are going to need that one-on-one support. And that's where a lot of work has come through digital health navigation, which have been new team members that have helped facilitate, implement technology into care. And I'll admit that digital navigation in and of itself is not novel. It's not new to healthcare. There's folks in the education field and the community field that have been doing this for a long, long time. But healthcare systems are just now catching up and just kind of going through. And so I'll tell you a story a little bit about our experience with at least a pilot that we did. So back like a year and a half ago or so, the Health Equity Committee for one of our primary care clinics, the Phyllis Gent Center, looked at some of these numbers over here. And this is our patient portal enrollment. And they saw that for Black and Hispanic patients, the enrollment rates were terrible, not good. But for Asian and white patients, they were a lot better, 80%. And so that presented a problem because we were trying to deliver so much care remotely, we were trying to deliver virtual care, and that's how we were using it. And so it really came from the Health Equity Committee for us to be able to say, we need to address this. And so we went about and we said, well, how are we going to do this? What are we going to do? And so we looked through what other people had done in the past, and the role of a digital health navigator came up. And luckily, at the time, there was, I don't know where this came from, but there was magical grant funding that existed somewhere. There's always that magical grant funding when you really need it. Where basically we can potentially hire someone for 3 months. And so we go, all right, we got to get on the ball and get this going. And so we went out and we were like, all right, let's go hire a digital health navigator. But what do you look for in a digital health navigator? And so here are some of the things we looked through, like some competencies, some thoughts about what a digital health navigator could potentially have and what they could potentially do. And so one of them is being very kind of personal, being able to make that outreach. Because sometimes when they're calling patients, when they're talking to patients, being able to make that one-on-one connection very quickly is very important. Much like, I don't know, I imagine them being like an anesthesiologist who you see very briefly just before they put you to sleep. You got to be able to connect really quick and trust this person very quickly because they're about to put you to sleep. So it's much similar in that you're able to connect with them very quickly. The other thing, they needed to have some technology knowledge to be able to at least troubleshoot most things. And then there's some things that we provided for them. Patient portal knowledge. We had them meet with our health IT leaders and our health patient portal team to kind of show them the ins and outs of the patient portal. 2, and then one of the key pieces was organizational awareness. So we didn't just want the digital health navigators to sort of like sit over there and like the rest of like the clinic is going on over there. We really wanted them to be like integrated part of the workflow. So as patients were coming to the visit, they were be able to engage with the digital health navigator. So we spent a lot of time showing the digital health navigator that we hired, here's how the clinic works, here's what patients are looking for. And then we provided them with not only clinical knowledge, in our case we focused on diabetes because we wanted to make this relevant to the patient's care. So it wasn't just like, oh, you can like refill medications and you can send messages. It was a very kind of like broad thing. We were like, you can refill your insulin, you can refill your metformin, you can ask your doctor about your A1C and your sugar levels to make it a little bit more relevant. And we provided the Digital Health Navigator information around that. And then the other thing was really focusing on equity. I remember I gave a small talk to Digital Health Navigator all about this topic, all around digital health inclusion, digital health equity, to really give them a sense of the mission that we were after. And so with all that in mind, we went out and we hired our Digital Health Navigator. And you see here in the white is our first Digital Health Navigator, Jean-Pierre Charles, JP, great guy. And then the rest of the team that came together to really drive this program forward. And it was a 3-month program where we really focused on patients with diabetes. And so we went all out. I'm an informatician, as you all heard. Informaticians love workflows. We love to like map out workflows. And so we developed this kind of workflow, the general sense being that we would call patients ahead of their upcoming appointment and either try to talk to them about the patient portal on the phone or enroll or set up a time for them to chat with us when they came into the visit. And the Digital Health Navigator kind of had to learn the best time in the workflow in the patient's experience through the clinic to kind of chime in. And then we called them after just to see how things were going. We also give the Digital Health Navigator some scripts to be able to work with to be able to talk to patients so that they just had a place to start. We also developed some training, and I will say here this. I initially actually on this slide it said pilot scripts and curriculum, and then I realized that the curriculum was probably the wrong term to use. So I switched it to training. My wife is in the education space, and she actually develops curriculum, and so I realized what we had done was not a curriculum. So I was like, let me change it to training. I think it's the right term. Please see me after if it's not the right term. But we provided a lot of information all around. So this one was around sort of like about their blood sugar control, what an A1C was, and how that kind of connected to the portal, and to try to make it a little bit more health context aware. And so what happened? And so directly with Digital Health Navigator, we ended up outreaching those 3 months around 420 patients. We were able to actually talk to 360. We signed up around a third of them. And I'll say, not on the slide, but I'll say that more than 75% of them ended up using the portal again. So we really felt that like that one-on-one contact was important. And then more broadly, as part of just kind of like general focus on the portal, we saw our numbers go up, especially among our initial target populations. Those numbers have since gone higher, but this is from our initial 3-month pilot. And it has generally been well received. We've been recently speaking to some of our clinicians and medical team around what their experience was like. And one of the big words that I think about is availability. There was a sense that before, it was always sort of a tack on that the practice assistant, if they have time, will talk to the patient about it. The medical assistant, if they have time, will do it. And now it became more of a focus where everyone felt like, okay, there's someone able to do this work and be able to focus on this. And so when we think about this, there's a couple of questions that come up. You might say, well, one, Jorge, you mentioned that you had magical grant funding. I presume at some point it ended. What happened to the program? Is it gone? So the program is not gone. It's morphed into our larger organization on a version of this program and has now deployed it. I think they've hired 11 or 12 total Digital Health Navigators. I think they recently completed their 10,000th patient contact, so they've really broadened out in the primary care setting. One question that comes up. And then the other question that you might have is, well, that sounds all well and good, but my organization may not have the funding to find a full FTE to dedicate to this. What are we supposed to do? And that's where I think a lot of the sustainability question comes in terms of how long can we, right now we're all excited about it, we're big focus on it, but how long can we keep a program like this going? And I think that's where we really have to focus and realize that a lot of these things that have come up are not unique to healthcare. And all of you, and that's why I love being here today, is that all of you have been doing this work for so long and understand this so well. And there's some level of humility that has to come from the healthcare system to say, all of these things are not unique to healthcare. We need help. We need to go out and collaborate with all of you to be able to understand this a bit more. So the healthcare system can maybe be one touch point where we're oh, okay, we're teaching about the patient portal, but maybe we can connect you to this community organization that's focusing on digital literacy and workforce development, or digital literacy and connection. So it's more of a spectrum because it takes time. Like even if we spend 30 to minutes to an hour with a patient on the patient portal, they're not going to necessarily be like super digitally literate off of that 1 hour. It takes more time than that, and I acknowledge that. So I think it's sort of a one touch point, and a lot of the policy environment that's changed. User number 3 for this as creating our new environment, which I think kind of would be able to support that. So that was our venture through technology literacy world. And so we've talked about the internet, having the device, now being able to actively use the device. But it's all to some extent not just on the patient. There's a lot of patient-facing things that I talk about. Patient needs to do this, patient needs to do that. But there's a lot of other components here around implementation and the way you actually deploy digital health tools that we have to address. And so when I think about it, it's really around 3 pieces that I'll mention. 1, kind of data monitoring as to who's using some of these. 2, some components around workflows. And 3, and I always kind of toy with maybe starting with this, engaging patients and families, because I think it's the most important point. And so in terms of data monitoring, I'll tell a brief story to say one of the early papers that we did wanted to look at the association between patient portal use and broadband access. And the short story on that is that we found that the broadband access had low patient portal use. But the problem with that study or with that data was that it only told me like a clinic it has 80% use, but I didn't know like who those 80% were. Was it just all of one population, all of another? I don't know. That's where a lot of the far at this point, and so being able to have work like this is again from colleagues at Johns Hopkins, where they actually developed a telehealth inclusion dashboard. You can imagine a digital health dashboard, a remote blood pressure monitoring dashboard, which gives you actual demographic breakdown of who's actually using these tools or not. And the interesting thing about what they did, it wasn't just they developed like a digital health equity committee that like meets over here and like main IT leadership meets over there. They actually integrated that into their review process. And I think that's a lot of what needs to happen is bringing a lot of these measures and these reviews directly to health IT and health organization leadership. So it's sort of integrated and ingrained within the way the hospital, the clinic works. So I think it's an important piece. The other point to this is around equitable workflows, and it brings up 2 points. One is around the struggle with interpreter services, and that's been a big challenge in delivering of telehealth. One of the big challenges in delivering telehealth to non-English or patients has been the fact that for some reason, it's been tough to get interpreters connected into telehealth visits. Some healthcare organizations have done it better than others, but that's a big point. And if you can imagine, if you're a clinician, and I think earlier in the day someone said, oh, you might have like 5 minutes to see or 15 minutes to see a patient. If you spent the first 5 or 10 minutes figuring out how to get the interpreter to work, you're probably be very excited to use this tool. You're like, well, I'll just come in person, or we'll just do a telephone visit, and sort of creates a weird incentive here. And so being able to kind of delineate those up front are important, and it's part of that initial process where we're like, okay, as we're thinking about a new digital health program, how are some of the workflows going to work from the get-go for some of our patients who are limited English proficient, health literacy? What are those going to look like? That's sort of one point around workflows. The other point around workflows is really around privacy and trust. I know we've mentioned this a bunch of times today, but I want to highlight it again. One of the things that we often hear is that, oh, telehealth is great. We can meet patients where they are. You can see into their environment. You can see their house and really see like what's going on and other potential drivers. But that sounds all well and good, but sometimes it sounds a little bit concerning. There's a lot of patients that already struggle with coming to the healthcare system and feeling safe, making sure that them coming to the health system doesn't have any legal implications. Especially we talk here about undocumented immigrants. What is it like to come to a healthcare system knowing that, is law enforcement going to be there? Is this going to be a time where I'm just trying to get healthcare? And this similarly and perhaps more impacts digital health as well. So you see behind me here some information showing that a lot of diabetes apps didn't have privacy policies. A lot of them were sharing information with third parties. Even the contact tracing apps were like, oh, this is great. We're going to track you. What does that sound like for a patient who's already struggling with trust in the healthcare system? Probably not so great. And so a lot of these apps were actually sharing, again, information with Google and Facebook. And what does that mean for us? I think it primarily means being able to have a discussion with the digital health companies that you're deploying and getting a good understanding of what their privacy policies are, who they're sharing data with. Because at the forefront, when I'm delivering care to someone, I want to be able to say, we're going to use this tool is right for you, it's safe for you, and then it's not going to have all where your information was sort of shared with a third party. And then, all these kind of negative downstream effects just from trying to get care. And the next part of this is around talking to patients and families. And it brings me to a story. I'm full of stories today. I had a discussion one day with JP, our digital health navigator that I introduced earlier. And we always, during our meetings, would share different stories that was going on. What patient story did you have today? What went well? What didn't? And so he had an interesting experience one day where he basically said, well, there was one patient I met, and I spent like 30 minutes to an hour with him explaining the patient portal, showing him how to use it, and the patient was just like, wow, this is like the best thing ever. I love patient portals. It was like great. It was like one of those commercials. I was like, oh, wow, that's great. That's wonderful. There was another patient that he said he's like approached and was like, all right, well, you need your email to sign up for the portal. And the patient was like, I don't have an email. I'm perfectly happy with that one. And so what do you do with that? If we're like a digital first healthcare system, what do you do with when you have patient preference that coming into the mix? And I think for me, it really brings up one, the importance of like multimodal care and being able to have all these different tools, right? If a patient signs up for a patient portal, making sure that they want to receive their patient information, their patient messages, their lab results through the portal, because they may sign up with you, but in the back of their head, they're like, I just want to still receive a paper copy. And so being able to have those conversations up front, I think, is key. And then also engaging patients and families as we're deploying these tools to say, this is how it's going to change care broadly. Is this aligned with how you would want to receive care? All right, so we've gone through technology access, technology literacy, and implementation. Now we're going to go into policy. I've teased policy a lot, so this policy section better deliver. And so when we talk about policy, there's sort of two components here. There's one specifically around telehealth, which we mentioned earlier, and how telehealth is reimbursed. And there's another component about the Infrastructure and Jobs Act that was passed at the end of last year. So with telehealth, one of the big reasons it took off, and earlier I showed you that magical weekend where everything shifted from in-person to telehealth. One of the big things that allowed that to happen were a few different things. One is the removal of kind of geographic limitations, so where you needed to be to deliver telehealth. It really kind of changed the way. You didn't have to be in a healthcare center. You could really be anywhere and be able to, I think earlier someone told a story about a patient, taking their telehealth visit in from their car or something like that. So it allowed things like that to happen and it allowed for reimbursement. The second one was simplification of interstate licensing laws. So I'm from Boston, Massachusetts, and we care for a lot of patients in Maine and Vermont and New Hampshire. And so it gave me the comfort, or the legal comfort, I guess, that if I took care of a patient in Maine, it would be okay, and I wouldn't be like breaking the law even though I didn't have a Maine medical license to practice. And three, it really brought reimbursement to be the same across different types of modality, whether you were in person, whether you were on the phone, whether you were in video. It kind of evened it out so that we could all, no matter, it was sort of like we just wanted to get patients care in any way, any form. And there's been a lot of discussion about what to do with a lot of these. I think the general point being that I think from my perspective, a lot of these should remain. The one thing I'll highlight a bit more is this payment parity across different types of modalities. And there, it's always a little bit tricky. On the one hand, I showed you data earlier. There are certain populations that are using telephone more for all the reasons we've talked about thus far. So if we then start saying, well, we're going to reimburse telephone less and video and in-person more, what kind of incentive does that create? I presume healthcare systems, because part of their goal is to bring in some cash, are going to be like, well, we want you to use video and in-person visits, and how do we as clinicians then interact with our patients in that way? Argument being, well, perhaps the care you're delivering on telephone is not of great quality. Are we saying that those certain populations that are mostly using telephone are getting not as because they're not getting in-person or video? And is that going to, having them first at the same level, is that going to continue that piece of it. Those are all great. Those are all questions that I have. Those are all key questions. I think I don't have the answer for them up front. I think there's a lot of work generally in the telehealth space. We need more data to be able to look at how we've done so far. But I would argue that for this point, I think maintaining reimbursement across different modalities is the way to go. Where we're still trying to care of patients, we'll catch up on a lot of the sort of indirect. Often talk about the direct impact of COVID, right, like the COVID disease itself, but what did that do to diabetes management, to cancer screening rates? Those all got a lot worse during the pandemic, and there's a little bit of catch-up that we're playing that I think having these types of laws stay in place would allow us to, at least for some time, be able to play catch-up. The other component of policy is the Infrastructure Investment and Jobs Act that passed at the end of last year. I've been teasing this the whole time. And as someone mentioned it earlier, and this, for those that don't know, those are not in the know, it's included lots of things, but included an interesting bit, which was a digital equity component, and it included $65 billion for digital inclusion. It was about $42 billion for actual laying down of broadband. Remember I was talking about, it'd be tough for a healthcare system to go out and lay down broadband. Well, this provides kind of a federal focus on this. $14 billion towards that internet subsidy I mentioned earlier. Again, speaking to sustainability of being able to get devices in our patient's hand rather than the healthcare system itself saying we're gonna find magical grant money and try to give people everything. This kind of gives it more of a focus here. And then the last piece of this is it gave $2.8 billion for digital literacy, fairly broad, and it presents opportunities, I think, for us to be able to collaborate with all of you here in the way we deliver those care. And then the last piece of this is that it tasks the FCC, which I think it's tough. We'll see how it goes, but to address a lot of the structural components that are drivers of digital exclusion here. So what does this mean for a healthcare system? I think it's a couple of things. One, around broadband infrastructure, I think it really provides the healthcare system has valuable data. As I said, the data around great, but if we start screening our patient, understanding their digital needs, this is data that you can then bring to your local and state lawmakers and say, here are we as a healthcare system, here's what our patients are facing, where can we deploy some of this funding that's come out to deploy that? The second part of this is around broadband device affordability. I've mentioned this already, but being a healthcare system, being an active stakeholder in promoting this program and saying, we're gonna push this forward, we're gonna screen patients and refer them to the Affordable Connectivity Program. The fourth part of this around digital discrimination is the healthcare systems and health corporations are big stakeholders. And if they step up and say, we've noticed that there are certain internet service providers that are not providing great service to our patients, that's what we're hearing. And we take that back to our state and local leaders and the FCC, that's important information that can move the envelope. I think the digital literacy piece, lots of work to be done there. I think integrating digital navigators is one piece of it. Being able to collaborate, in my dream, there's some sort of, part of my dream is that we are able to use this funding to kind of collaborate, and I imagine this collaborative where we're all working towards developing a patient's digital literacy. The healthcare system plays one role in developing the patient portal, the telehealth piece, but we then refer them to, Joanne, who's workforce development, and then Tim, who's doing more education development, and then Juan, who's doing more on voter enrollment and all these things, and we're all sort of working together, building up. And if you take a zoom out for that patient, that person's experience, you basically find that their digital literacy overall went up. And that's sort of there's a dream that I think that could potentially happen here. And then the last piece of this, which I think is really unique to healthcare system, is with all this, if you look at all this, that's a lot of money. I don't even know what that would look like right here, but it's a lot of money. One of the things we want to be able to show is that in the investment of this money, we really made an impact on a patient's health and a community's health. Because if at the end of the day we don't do that, then it's going to be hard for us to say, well, we should get more funding. It's like, well, how'd their diabetes do? Well, I don't know. But probably good, I think. I don't know. So I think it's really up to healthcare systems, and as healthcare systems have that uniquely. We have that data around our patients' A1Cs, our patients' hypertensions, our maternal fetal outcomes, our behavioral health outcomes. So I think that's sort of a key component there. And then I think it really allows us to treat digital health inclusion as a social determinants of health. Again, it kind of goes back to my dream of being able to bring this together across the spectrum of a patient's general experience. And so I'll end with a couple of points on the standard of care. One is one of the studies that we did that I showed you earlier showed this gap in video visit use. Certain populations were using them, certain populations were not. And I pointed to a lot of patient-facing things. Well, patients who were from this area, they didn't have broadband. But one of the interesting things that we found in that study too was that even though patient-level drivers were important in that gap, there was also organizational drivers, which we talked a little bit about, but also clinician drivers. So that the patient was also kind of a key driver to it. And it's made us wonder, and luckily someone looked at this, and they basically said, let's look at who gets even offered, not even like who uses it, who just gets offered certain types of visit. And they found that certain populations were more likely to be offered a visit over a video visit. Now there's probably multiple explanations for it, but one of the things that comes to mind at least is there's some component when you're at the point of care that you're making to say, this person will or will not use digital health, and I perhaps will make that decision for them instead of having the conversation with them. And this is what the data said to me. And so I think it reminded me that you can't tell a patient's likelihood of using a digital health by looking at them. You really have to have that conversation to say, is this the right tool for you? Is this the right tool for the patient? And not make assumptions about how they look or whatever it is about whether they're going to use a tool at all. And with that, it brings me to my last point, which is really around, I've been talking this whole time about digital health inclusion. Like, man, this guy's a real technophile. He just likes technology all the time. But in reality, I really view technology as sort of a means to an end. Right? My goal here is not to have, for everyone to have computers. Well, it is if it gets me to my ultimate goal of health equity. Right? I want to have healthy patients, healthy communities. And we're all working so hard on this because we believe that digital health tools are going to get us to that point. But I think that's why it's important to go back to the impact and say, is it having the impact that we think it's going to have? Because if at the end of the day, all my patients had laptops and devices and internet and digital literacy, but their diabetes outcomes were just like not good, then like, maybe that was the wrong way to go. Maybe investment in like a food pantry, housing stability, maybe that was the better way to go. And so never losing sight that our ultimate goal here is really health equity rather than purely digital inclusion. All right, and with that, thank you so much for listening to me. I know it's the end of the day, and you guys are ready to rock and roll. So thank you for staying with me. Always happy to answer questions. As I said, I do use Twitter, so feel free to reach out. But thank you so much.
Hi. You mentioned that your colleague did a dashboard at Johns Hopkins for, so you would be able to see which patients were using things and what the uptake was at clinics and stuff. In healthcare, sometimes the demographic information isn't always filled out, so it's hard to get that data. Did they do any extra interventions, maybe with, when patients were checking out to verify data, or how did they fill in that missing data?
Great question around data missingness. Always a challenge when you're doing health equity work. I can't speak for my colleagues at Johns Hopkins, but I can speak for our organization. And our organization has had efforts to really focus on ensuring that data is captured appropriately. And one of the things they've done has been in training a lot of folks that captures data are folks at registration and doing a lot of kind of cultural training with people at registration to see like this is how you assess someone's race, someone's gender, someone's ethnicity. And so that's how we've addressed a lot of the missingness. And even now, I was earlier today working with some data, and there's still a ton of missingness. So I think it's still sort of a challenge overall. But the way we've approached that was kind of going to the point of where this data is being collected and trying to work with those people to say like, how can we best kind of capture this from patients?
Thank you. I had a question about the Digital Navigator program that you've been running, just sort of on a practical day-to-day level, how much one-on-one help that is. So like the navigator sits down with a patient to help them with the system. how much time are they able to spend together? And is that one visit, multiple, those
Yeah,
kinds of things?
that's a great question. I think it sort of varies. I think on average, it's been anywhere from like, but the range has been 50, 20 minutes. But that range has been some, as I said, one of the stories like they spent an hour with the patient. And so that sort of has spoken to us about patients that are coming, as we all talked today, at different points. And then two, it also though speaks to sort of the kind of the scalability of the program, right? If you're trying to scale this across a whole organization, are you going to, ideally you would capture every patient coming into the door, but if it's taking you 30 minutes to an hour with each patient, it's probably going to be tough to do that. And I think that's where a lot of the, ideally you would have something that's a little bit more self-directed for some patients, or something where you could kind of have the human element play a little bit of a lesser role to just make it a little bit more scalable. Because I think like you're suggesting it can get a little bit tough to like see every patient. And in talking to our clinicians and our navigators, some of the feedback is that sometimes they're just very busy, and so it's like, oh, I felt bad because there was a patient waiting for me, but I was working with another one, so I had to tell them that I was going to call them later, and so they end up trying to call them later. But teaching someone how to do something on the phone is tough. It's a tough thing to do. Nope.
Yeah, right here. I am a rural Texas library director, and a week ago I posted your JAMA article on LinkedIn and said, librarians, we need to be part of this. We need to have a seat at the table. So I can't believe I'm sitting here now listening to you. It's awesome. So as a rural library, public health is a big interest of ours. We have a telehealth room. We want to be involved with this. One of my questions that I don't know the solution is compensation. So when all the government money runs out, whenever that is, 5 years from now, as a library, we're left doing that digital literacy piece and having the technology and the fast, robust connection. And I'm trying to figure out how libraries can get a piece of that pie, and not just the healthcare providers getting all the compensation, while we're half of that equation as well.
Yeah, and I think it goes to, I think it brings up 2 points. I think one, it's one stakeholder that I did not mention super extensively here is the payer. So what are the role of insurance companies in like reimbursing some of this, reimbursing whether it's just the technology access pieces or a lot of the work that you're doing, if we're really kind of viewing this as sort of a socio-determinative health and something that we should all be working on. And I think the other piece I think it speaks to is trying to collaborate with your healthcare organizations nearby, because I think it presents a pretty strong front to say we're working with X healthcare system to be able to deploy this, and perhaps in that way you can get some of the funding is routed to your library in addition to the healthcare system. But so I think it's collaboration is one potential, and then the other one, which I think is more of a longer term play, is sort of trying to see what the appetite is for payers and insurers to kind of cover some of this, because I feel like at some point the federal funding will end, and so we'll have to sort of need a more sustainable solution. And so I think payers could potentially play a role there.
So I had a question about the slide you had about who's offered
Yeah.
digital options. Were those people that have been offered it or not offered it?
Those were people that were offered the audio version of the visit.
Oh, I see.
Yeah.
Okay. And do you know of any any studies on whether seniors are offered? What seniors are offered?
For
Just
this
curious.
study, for use. For use, there's definitely differences in older populations using telephone or audio over video. I'd have to think back on this. This is one of the only studies that I've seen in terms of like offering, just because we can capture whether someone uses the telehealth or not, but whether they get offered, it's more kind of, this was a survey that was done, and I'll owe you that when I forget. This is sort of what they mainly reported, and I think they didn't find a difference in the older populations, but don't quote me on that. But this is sort of one of the only studies I've seen that has been around the offering piece. But I will owe you the answer to the elder population.
I'm Dan Ross. I'm the chief medical officer for the Medicaid program for United Healthcare here in Wisconsin.
Awesome.
And at the beginning of the pandemic, obviously everybody in Wisconsin quickly pivoted to telehealth. But we have found that especially with a lot of our members, again, all Medicaid members with social determinant of health issues, that the telehealth has really been very helpful, provided that they have all the other things that you talked about, the broadband access. So we are very much in favor of continuing to compensate, reimburse the telehealth at the same rate, because I think it's reaching out to people in some ways that we maybe had missed in the past.
Yeah, thank you for sharing that. That's yeah. Clap for that. Hooray. Yeah, that's a great point. Thank you.
Yeah, at Envision America, we work a lot with the blind and visually impaired as well, and there's been a huge amount of people talking about telehealth and utilizing that because they don't have transportation most of the time anyway. And I also wanted to comment on your comment about retrofitting websites. It's really difficult to retrofit a website for the blind and visually impaired and make sure that it's JAWS compatible, and that's something that a lot of people have a hard time accessing the web portals and stuff because they're not compatible with the visually impaired. So,
Yeah, I think that's such a good. But I'm a part of my training has always been being a lifelong learner, and I'm still sort of learning about all the different pieces that it takes to retrofit a website for the visually impaired. So that's a great point.
Hi. To sort of continue with the theme on disabilities, I work with a lot of families who are doing therapies online with their kids, occupational therapy, speech therapy, and stuff like that. So I'm just saying, in your experience doing this in the hospital setting, are they including those types of telehealth visits in addition to the primary care and the strictly medical visits?
In terms of like the data that we're capturing, or in terms of in what context?
Well, I guess in the context of offering navigators to help people through that, because they don't always happen in the hospital setting. Well, I mean, obviously telehealth doesn't, but just in those departments, are you offering navigation, I guess?
Yeah. The initial program is primarily focused in the primary care setting, but the way we've deployed it is basically trying to departments. So for example, we have like a tablet program that comes with navigation that's set in the OB department. And so for people who are being discharged and need kind of close follow-up after pregnancy, that's sort of been one non-primary care setting that's been developed. And there's been a big focus on sort of like behavioral health more broadly, because I think that's been a pretty big uptake. But totally acknowledge that there's a lot of work to be done. I primarily, I'm a generalist, so I focus primarily on kind of primary care topics, but definitely a lot of work to be done in all realms of medicine.
Hi, I have a question. I'm Lori Manteville. I work with Metastar, and I've done a lot of work, especially with tribal health organizations and a lot of other organizations that don't necessarily have access to the really good EHRs like Epic, Cerner, those that are really using kind of other barely certified, if I may, that don't have the sort of the bells and whistles of being able to, or that it's more expensive to get those kinds of subscriptions for the patient portal, so they're using sort of the lowest thing. And also, sometimes providers still also in staff also need some training. Can you speak to that at all?
Yeah. I think that there's a lot of great points there. I think one of them, totally agree. In my previous job, when I was at Lawrence General Hospital was a much smaller shop. And when I got there, they were using a barely certified type of EHR that really didn't have a portal at all. And so you can imagine Lawrence is primarily Spanish-speaking, primarily Dominican population. And so we were basically sort of not delivering the same type of care that they were getting 30, 40 minutes down the street in Boston, where now we have very, very fancy EHRs. And so I think there's a great component there around what platform, the role of platforms and vendors in that, and how you actually implement it. And I think to your second point around training, I sort of introduced this slide specifically by saying that some component of the gaps that we're seeing in digital inclusion are driven by clinicians, and I sort of used it to highlight this piece around bias. But the other big component of this is comfort and ability to use these tools. And so one of the other work that we're doing is around kind of like the safety of telehealth visits. And so we're looking at like abdominal pain and doing some work to understand if you're assessing someone with abdominal pain is sort of interesting because usually you rely on the physical exam to be able to do this. And we don't have teledactyly like those folks in 1925 thought we would have. And so it's a little bit tougher to do. And so is that, do we need new training to be able to do that? I know like the AAMC, the group of academic medical centers, has released like telehealth competencies, which are basically these like 6 domains of like, as a clinician, as a provider, here's the things you should be able to do. And a lot of this is thinking in the context of like medical education as we train sort of the next generation of clinicians. How do we include all those pieces? So I think there's a big component of clinician comfort, clinician training. Is this the right? Am I doing the right thing here? I hear you on the phone. Do you sound okay? I don't know. Maybe did your voice creak there? Does that mean that you're sick? I don't know. So there's a lot of big component around like clinician comfort and training that definitely plays a role. Oh, hello.
Hi, not trying to give you whiplash.
Yeah.
I'm Jerry. So I'm curious to know if there have been any efforts to include family caregivers in this work, because my mom's 90 and she's actually incredibly comfortable with technology, but I don't think she's ever going to use MyChart, but it's incredibly valuable to me. And so I can log into it, but if I need to reset the password, it like goes to her phone and I need to. So I also think, yes, she may or may not have internet access or feel comfortable using it, but I'm incredibly comfortable using it, and increasingly, especially with an aging population, that seems maybe even more important than assessing, can the patient use it, who is their caregiver, and can they use it? So.
Yeah, that's a great point. I think the care partner piece is such an important piece. One of the key things that we've been working through the workflows on has been sort of like the proxy access, which I think is what you're referring to, and understanding who has access to what, how to make it easier for you to be able to do that. Anecdotally, I'll say that it's been interesting. Sometimes I do research on like the actual messages that are exchanged, and every once and again when we're looking through the messages, we see messages that are like, "Hi, this is not the patient. This is like Jane, her daughter. I'm just using her account. I had a question for you." And so how do we make it so that you're not like using her account and make it? So I think a lot of the proxy piece of it, I think, is really key, but requires just like some deeper implementation, and a lot of the workflow pieces that I mentioned kind of go into that to be able to have that understanding.
All right, well, thank you, everyone. I think we're almost out of time, and I want to invite everyone to stick around for a poster reception, which will be out in the Nolan Gallery in the hallway here. And everybody help me thank Dr. Rodriguez for his wonderful talk. And we look forward to seeing you at the reception. Thank you.